The Love Doctor, Episode 014, Timeless Intimacy, Endometriosis, Bioidentical Hormone Replacement, Urinary Incontinence, and Platelet-Rich Plasma, with Edward Tangchitnob.
This is Dr. Charles Reynolds, inventor of the O-Shot, and thank you for joining Dr. Emily Porter, the Austin Love Doctor, as she openly discusses your most intimate questions regarding relationships, sex, and personal wellness through the eyes of a medical doctor who treats men and women for a variety of sexual issues using the latest medical advancements available. Get comfortable, relax, and welcome your host, Dr. Emily Porter.
So hello, thanks for joining us. It's Dr. Porter, the Austin Love Doctor, and I have a special guest today, a friend of mine and colleague named Edward Tangchitnob. Edward is Dr. Tangchitnob, as I should refer to my colleague, is a physician out in West Covina, which is the LA area. He's a urogynecologist, so he has an MD degree. He has a degree in engineering and then an MBA. And then he did his residency at Cedars-Sinai out in the LA area. And he's got a fellowship in urogynecology and robotics. So he does a lot of really cool stuff with robotic surgery for women who are having hysterectomies and other gynecologic procedures, pelvic floor reconstruction, and vaginoplasties, which is kind of a hot topic right now. And he has a really cool technique that he uses and has trademarked to help women who are having to, I guess, have a hysterectomy, but don't want to just get thrown into menopause all of a sudden, which is what traditionally has happened. So he's really considered an expert in his field for that. Has a lot to say. He's a bio-T mentor out in the California area, and he's a speaker for lots of different companies, a national speaker on several different endometriosis drugs. And then also for Alma lasers, he uses the FemiLift device, and then also various surgical endoscopic companies. And it is really hard to pin Edward down because he is always traveling somewhere, giving a lecture somewhere, having a dinner, helping educate people. And so I think there's a lot here, and I am happy to introduce Dr. Edward Tangchitnob. And thanks, Edward, for joining us.
Thank you, Dr. Porter. It's such an honor to be a guest on your show today. And I just want to start by saying that, I think what's out there right now for women in terms of intimacy has been lacking. And what I mean by that is that there are instruments and there are techniques. There's even books and literature on intimacy, but there's just so much out there that, sometimes it's difficult and can be a little bit overwhelming for women to start. And, with me leading with that, over the last year, I finally was able to develop a system or a method in which I call timeless intimacy that really summarizes a combination of different techniques and treatments to help women become intimate again. So what is timeless intimacy? Well, timeless intimacy is a combination of procedures that includes a small surgical procedure, which has commonly been known as vaginoplasty, which many people know as tightening, and O-Shot, which is the use of platelet-rich plasma, that is your own blood with the healing factors injected down below vaginally. I use the FemiLift CO2 laser, which involves the small heat into the vaginal canal, which rejuvenates the vaginal mucosa, as well as optimizing the patient's hormones, specifically the testosterone. Now, individually, each one of these procedures works great. Vaginoplasty, for example, begins to bring together the parts of the vaginal vault that have become lax with time. You throw in 2 or 3 kids later, and intimacy, quite frankly, just doesn't feel the same anymore. Now, when you start adding the combination procedures, we're finding, at least in our institute, that there is a certain amount of synergy in which the procedures start working together. That is, the procedures themselves really do become the greater than just the sum of their parts. And so if you think about it, patients who've had multiple children, and let me just say that I'm actually coming into a practice, joining my father. He's been an OBGYN in our area for 30 years. So most of the women now have completed childbearing and are entering the menopause stages of their life and are telling us not that they want to come back in and have more children, but instead they're having issues with their intimacy. And so we're finding now that the population that was once pregnant, giving birth, having children, the needs have changed. The needs have shifted. And I feel such an honor to come back to join my father in his practice and really develop a solution that identifies and helps address many of these issues that are associated with intimacy after childbirth. So that being said, I think the combination, Dr. Porter, of all these procedures has really provided synergy to get patients to feel younger again with regard to their intimacy.
Yeah, we do a lot. I don't do vaginoplasty yet, although from what you tell me, I could get good at it. But yeah, we do O-shot and Diva for sure as a vaginal laser as a combo, and I actually put PRP and squirt it into the channels and rub it into the channels that the laser makes to get really no downtime. I mean, it's amazing. We tell them not to have anything in the vagina for 48 to 72 hours, but most people, they're not uncomfortable at all. Like you don't even need a Tylenol. It sounds horrible, but I think I tell people if they wipe, it might feel a little like they had some dry sex. Most of the women, especially menopausal women, if they haven't been on hormones, are already having so much discomfort down there anyway. This is like a relief. And then the BioT. So when I do it, I try to, and I'm sure you do the same way. If you have somebody who's menopausal, they're 52 years old, that maybe your dad delivered the babies, which I think is so cool that you guys are multi-generational and you're just the new phase. When you have children, like what's going to be available then if they decide to become a gynecologist? So like if I'm 52 and I decide that I've had menopause and it's kind of uncomfortable when I have sex, I would do the pellets first, right? Like, so talk to me about what your approach would be, in what order you would do these. If I don't have the vaginoplasty, but I would do the pellets for at least 3 to 6 months in combination with maybe some intrarosa, something to get the vaginal mucosa like healthier and thicker so they're not drying and cracked and it responds better to treatment. Then I would do the Diva with the O-shot at the first treatment, and then the other 2 a month. But I don't do the vaginoplasty. So tell me how you do it.
Well, I think you nailed it
what
right
your
on
order is.
Because the patients who are coming in, regardless of the degree of prolapse or the degree of vaginal laxity, are really unified by one thing, which is hormone imbalance. Because a lot of these issues are, to your point, Dr. Porter, they're started by the whole issue with hormone imbalance. Changes in estrogen, changes in testosterone begin to change the collagen structure vaginally. And so it's a lot easier, I think, to see, and I know you do a lot of aesthetic medicine, but it's a lot easier to see on the face because facially we see the different parts of the cheek sag, you get wrinkles, but vaginally or intimacy-wise, it presents with vaginal laxity and prolapse. And so patients come in with multiple issues and multiple complaints, and I have a very similar approach. I really do try to educate the patients on hormone optimization first. In our practice, we use pellets, just like with your practice, we use BioT, and every patient is different. Every patient is different with regard to their labs and what their needs are. And being as that, we create custom protocols, custom treatments that use different doses of the pellets that go under the skin and release hormones for about 4 to 5 months at a time. As a side note, we also treat men in our practice, and I always joke with the patients that, listen, once you start running circles around your husband, it's trying to bring your husband in, right? And so,
I find that I'm finding that a lot too. An imbalance definitely is not as much fun as when both people are on the same page. So,
absolutely, and as a gynecologist, an OBGYN, I didn't think, at least graduating fellowship, that I would be entering a space where we're treating men. But listen, when we're doing intimacy, we have to have a very holistic approach, just like with your practice, in which we treat the men too. But going back to your first point again, I think it's really important that at a baseline, we get the labs just to see where the patients are. And patients are entering not menopause, but sometimes they enter perimenopause, in which the testosterone begins to decrease. If the testosterone begins to decrease, libido decreases. And so I could come in and perform a vaginoplasty, which is surgical tightening or a surgical procedure. But if the testosterone is not optimal and they lack libido, then they have a surgically corrected or surgically augmented vaginal vault, but their hormones are not optimal and they don't really desire their husband. I had a patient of mine recently say, before she had the bio-T, she would come home and see her husband and say, I don't remember marrying that guy. And, after getting pelleted, getting some testosterone, she came back and said, that my husband looks kind of good. And I think these common stories really unify the patients when we begin to optimize their hormones. And to going back to why I created Timeless Intimacy, there's multiple ways to enter the protocol. Now, as you know, with a lot of the procedures we do, by combining all of them, you get the most optimal protocol. But that's where I really think that sitting down with the patient and identifying what their pain points are is just so important. If I have a patient, like I had one last month, that had a stage 3 prolapse with the cervix hanging out, no amount of hormone optimization is going to be able to correct, something as severe as that. So, doing robotic surgery with pelvic floor reconstruction and a concomitant hysterectomy to try to lift everything up, and then possibly doing a laser. I use FemiLift by Alma, or doing hormone replacement at the time of the post-op is going to be great for them. In our practice, we see a variety.
I ended up having to have. Go ahead. Sorry.
I was going to say that.
Finish up. Sorry.
You see a variety of different kind of patients entering, and it depends on how many kids you have. I know you, for your own experience, and you've had experience with some of this yourself, haven't you?
Yeah, I had 4 kids in 4 years, and after the first one, like 4 months after and she was like half hanging out, and she just needed a little tilt, and then one push and she came out. But I was diagnosed with a rectocele and a cystocele and pelvic organ prolapse, and it was really uncomfortable. Thankfully, I have estrogen, no problem, but I think I had my baby, had that, and then it was after my last child was born, my 4th child, that then my order was I actually did Diva O-Shot first, and that helped a lot with my incontinence that I had, like a lot, and with lubrication, which was really, really uncomfortable for me before that. And then a few months, maybe 3 to 4 months in, then I added bio-T. So then now it's like I added my libido in. And then it wasn't until, 2 years later that I went and had surgery when it was convenient for me. And I didn't have any tightening, but I had pelvic floor reconstruction and had a hysterectomy. They left my ovaries, but.
Well, I think what's really great about your particular situation is you had non-invasive office. You had the bio-T and you had the Diva, and that actually bought you some time before you actually had to come to doing the surgery. And I think that's what's really changed in the last 5 years is the ability to really push the envelope on non-surgical in-office procedures for intimacy and vaginal pain. And when we think of vaginal pain, the technical word for vaginal pain is dyspareunia. That's pain associated with intimacy, so dyspareunia. And, there are a variety of different reasons why patients present with dyspareunia. When I think of how I counsel patients, patients who are generally younger, who have dyspareunia, it's usually because they have endometriosis. The older patients who have dyspareunia, again, painful intimacy, it's because they have a lack of estrogen. And so it's estrogen that really has 2 faces to it. So when you're younger and you have too much estrogen, you have implants that grow all over the pelvis and parts of the upper vaginal vault. Too much estrogen could cause pain with sex. Now, when you're older, the lack of estrogen and the lack of estrogenization into the vaginal mucosa itself can also cause pain. And so what that means for our patients is that it's quite confusing because on one hand, too much estrogen could cause pain. On the other hand, too little estrogen could cause pain. And so I think, as part of today's webinar or part of today's podcast, I think it's important to at least introduce that to your listeners on the show is this idea, a tale of 2 hormones, really is estrogen having 2 faces, right? Too much can cause pain, too little can cause pain. It's the same hormone. And I just think it's such a interesting facet that many patients are out there trying to understand and grasp as they're going online and trying to find out why it is that they actually have pain with sex.
I think it's kind of like Goldilocks and the Three Bears. That has to be just right, not too hot, not too cold, but just right. I can tell you, I got shamed from my urogynecologist when I went last year, and he did a fantastic job with surgery. But when I told him I was, doing testosterone pellets, he shamed me. When I told him that the Diva had helped a lot with my incontinence, he didn't know even what like any vaginal laser was. He didn't believe in any of it. He was just cut, and how that had helped me, and he thought it was all hogwash. And then I don't know if I told you this, but after my, here's the thing, with the availability of online information and people listening to podcasts and just patients being educated, I think that physicians working in any particular field need to put our egos aside. And we need to realize that just because that's not something that we offer, that it's not valid, just because the societies that we belong to are way behind the times doesn't mean that something is unsafe. And we shouldn't be shaming patients for doing things that we have no evidence are harming. All these 20 years of data of safety of studies, they want all these randomized controlled studies and things, but you should never be shaming a patient because you're not living their life. Okay. He wasn't living my life. He wasn't in a sexless marriage because he didn't have any libido anymore. The same physicians that never told me that birth control would completely tank my libido, that it bound up all my testosterone. All they touted was, oh, it's going to help you so you don't get breast cancer. Oh, it's going to reduce your risk of ovarian cancer. I was on the pill for basically 20 years at least. And I never knew that it had any effect on my orgasm. I never knew that it had any effect on my testosterone. And it's kind of a sick trick, right? Like, oh, great. If you ever want to have sex, then you're less likely to get pregnant. But you're not going to want to have sex because you're on the pill. And I just think that they just need to take it easy on patients and educate themselves and not shame everything that they don't know. So after my better, but then I had pain, which I didn't actually have before. I had dryness, I had some incontinence, but I didn't actually have pain. And because he pulled the perineum together, which is that area between the vagina and the anus, I never had any pain with sex. But I think maybe the stitches that were there, all of a sudden now I'm having pain. So do you think I went back to him and said, hey, now I'm having pain? Oh, hell no. I was teaching an OSHOT class, and I had my students inject some platelet-rich plasma right in that area after they did an O-shot on me. And I'm not kidding you, Edward, within 1 month, that pain was completely gone and it has not come back. I don't have any pain with sex anymore. And that was what we did. We just injected a little bit into that area. There was like a little small fissure there, I guess. Crazy. But I don't want to have to feel ashamed to tell him that, but he shouldn't have blown me off,
Yeah, and I think it's great that you actually took the time to evaluate yourselves and treat yourself. But we have a subset of the population that have lichen sclerosis. Oftentimes it'll grow in that area above the perineum, near the fourchette, and it can be extremely painful. At least in our institute, we have a series of patients coming in for O-shot injections there. And, classically the O-shot is injected towards the top of the vagina. But to your point, we've had patients had a lot of success with decreasing amount of pain from an old perineoplasty scar or old episiotomy scar, lichen sclerosis, which is inflammation of the vulva and vaginal vault down there, have relief of pain there. So you're not alone in this. We've had other patients in our practice also injected with PRP with similar results. I think a point I was gonna make is that there are a lot of devices out there, right? And so when patients come and they Google, and they'll bring in their Google, search, and it'll say vaginal rejuvenation with the laser or RF. The first thing I try to explain or educate my patients on is the difference between the two heats. Okay, so our patients come in I say, well, this doctor says, my laser's better. And another doctor says, this other device, which doesn't use the laser, which is called radio frequency, is better. And to be honest with you, jury's out. I mean, both are heat delivery system that get heat applied to the vaginal mucosa or the vaults. And, because of the heat, there are heat shock proteins that actually exist in the vaginal mucosa, which upon stimulation create more collagen. I think that's the basis for both. I don't know if your patients are asking what the difference between vaginal laser and radio frequency is.
I tell them that radio frequency is probably equal for tightening, but that you're not actually, with Diva, we're actually turning over the mucosa. I mean, and it's automated, so it's 3 minutes and it's not operator dependent. So you can basically hold it there and it does its thing. So you're not having areas where you're double treating or having skip areas. Whereas every RF or radio frequency device that I know, you have to go in and out, in and out, in and out, kind of turn it. And it doesn't actually cause a complete sloughing of the vaginal mucosa. I have the benefit of that most of our patients that get sexual wellness services with me have also had an aesthetics consult, and Diva is the halo of the vagina. So I've already explained it to them in terms of the halo for their face and how one is, they're aerating the yard and one's heating and one is ablating the tissue or vaporizing the tissue. And then I'm saying, it's just the exact same technology for your vagina, and that kind of clicks with them. So
I think that's a great point. And, the difference is really between laser and radio frequency is the modality. With the laser, what we're doing is we're exciting gas that's in the chamber and applying focused heat, versus radio frequency is more of a bulk heating event with the hope that enough heat gets to where it's supposed to grow some collagen and or stimulate new blood vessels to grow. But to go back to what I have kind of created, which is the timeless intimacy, you could technically use either, because the whole point of it is to stimulate the conversation. It's to start the conversation with patients about if there is a possibility of going back to a time, almost in, to your point, a Goldilocks event where it's not too tight, it's not too loose, it's not over lubricated, but it's also not under lubricated. And in our practice, as with yours, sex should never hurt. When we are young, or when women are younger, I mean, it wasn't that it was painful. And how come when you get older, it feels different and it's painful? And that is the question that we should query, I think, as physicians. I had a patient of mine that comes to mind about 2 weeks ago. I was doing the bio-T evaluation on her. She filled a checklist of symptoms. We drew her labs on her. He was like, "Oh my gosh, I don't want to have testosterone." And she's 35. "I don't want to have testosterone. It's going to turn me into a man." And I don't know if you get that at all, Dr. Porter, but when I get that, a common kind of scenario that I try to pose back to the patients is I ask them what they were like when they were 21. And most women will say, "I felt good, I had good libido, I was vibrant." And I usually follow up as a corollary, well, that's usually when your testosterone is the highest. You were probably not man-like. If anything, you felt your most vibrant and sexiest at the age of 21. Yet somehow, as a society, both medically as well as just in the community, testosterone replacement for women is shunned or is looked down upon. I wonder why that is.
I think we're just really far behind. I mean, if you look at the number of drugs to treat, just prescription medicines to treat male sexual dysfunction, Cialis comes to mind, Viagra comes to mind, Levitra comes to mind. There's another one. There's at least like 3 or 4 more that I can't even name. Stay something. I mean, there's like probably a dozen of them. And for females, we have one. And I won't say it's bullshit, but it's bullshit. I mean, because it's an antidepressant, which is what they always try to say is the reason why women don't want to have sex, because they're depressed. And if you take it every single day, 30 days for like 3 months later, then you'll want to have sex 1 time more per month than somebody taking a sugar pill. So for several $1,000s a year, you're going to get laid 12 more times. And it's not even going to be better. Whereas we know testosterone is really responsible for libido. We know that testosterone plays tons of effect on orgasm. In addition to the fact that, I have osteoporosis in my family, my bones are going to be healthier because I'm not going to have osteopenia the same way. I have a lot of family history of heart disease. I know that I'm lowering my cholesterol risk. I'm being active right now and really working on walking and getting healthy. And my scale hasn't changed nearly as much as the comments that I'm getting about how good I look. And because I think I'm just leaner, and so many other things that testosterone does, the brain fog and all that stuff. And I think it's really, we're going to look back on this and see how cruel physicians, traditionally male physicians, and they tend to govern all these boards, were for missing this. I think that there are people like Dr. Runnels who were using testosterone 20 years ago, like Dr. Donovitz, the guy who created BioT, using this 20 years ago, and that they were so shunned, and that they're really we're gonna go back and we're gonna realize what a crime we did to all these women. That's my take.
Absolutely. Well, in our practice, I have the honor of practicing and operating with my father. I call it the mom test. Like, what would you do in our practice? This governs the whole mission of our practice for your own mother. My mom's been on BioT for 2 years now, and she's
mine too.
Amen. She has been on testosterone pellets and looks and feels the absolute best she has in years. So when I first graduated from fellowship, I remember coming home and seeing my parents in 2 separate bedrooms with EHR. They had just literally adopted the electronic medical record system into their office, and they were not talking. They were overweight. They weren't walking. They weren't living their best life. I mean, it's easily put. Just they were not living their best life. And the thought of doing any kind of hormone replacement other than Premarin or Prempro, which is what my dad has been using for some time now, and keep in mind, without testosterone, was really all my mom had. And so she would take it invariably because it didn't really do anything for her. And it might cause her to have less dryness kind of throughout her body, but it didn't really do anything in terms of her ability to get up, enjoy grandchildren or go exercise. And over the last 2 years, I really have seen a transformation in both my parents, both my mom and dad, who, at the age of 64 are active. My dad is still operating. He's doing complex surgeries every week on the robot, and he's sharp as a tack. And, 1 in 3 post-menopausal women, have some kind of cardiovascular acute events or stroke, right? And that's actually higher than the risk of cervical, uterine, and ovarian cancer combined. Yet that's all our preventive medicine focuses on, Dr. Porter.
Yeah, and we focus on breast cancer, not that breast cancer is not severe and common, but we have a whole month dedicated to that. And I know we have February dedicated to women's heart disease, but we don't have the fundraising and there's the pink ribbon on everything, but there's not anything like that for heart disease. And we have something and we're ignoring it. And that's super frustrating, I think. My mom was the same way. She was using the cream forever. And she told me within a week of going on BioT and having the estradiol placed that she had way more effect just from that alone than she did of years of the cream, in addition to all the other health effects from the testosterone. But, we still have people out there, including our own colleagues and peers, especially the ones that are gynecologists whom you train with, and they're still waiting for a study of hundreds of thousands of people or more where they randomized people to 2 different groups and gave some of them hormones and some of them sugar pills, and proved that these things were real and that there was no harm done. Can you talk a little bit what I tell patients, but when you have somebody who asks about the safety of estrogen specifically, if we just want to stick to that, and you bring up the Women's Health Initiative that was, I believe, in 2001, that was around 67,000 women, how do you reconcile that study with not only your patients, but with your colleagues in terms of what BioT or what, bioidentical estradiol is versus that, and reassure them?
So I'm very disappointed because when I was trained in residency, we would often refer to the WHI study, the Women's Health Initiative study, as the landmark paper or the landmark study that looked at hormones, not knowing at that time that study was responsible for taking away a lot of women's hormones all in one fell swoop. And what I try to tell the patients, because some of my patients are quite savvy and they'll bring copies of the paper to my practice, I will ask them, do you know what the difference is between a bioidentical hormone and a synthetic hormone? And most women will say, no, it's all hormones and they all cause cancer. And so, in the time we have with our patients, we try to make it as efficient as we can and educate the patients while trying to dispel bad information, right? And that's actually the most common confusion point, I think, for our female patients is, well, actually male patients as well, but it's what is a bioidentical hormone and what is a synthetic hormone? So a bioidentical hormone, in our view, is a hormone that's been created usually from a plant source that looks exactly structurally, chemically like the hormone that your ovaries or your testes for men used to produce, versus a synthetic hormone, which is synthetic. It's your body's never meant to see anything estrogen or testosterone like. And so we hope, or at least the scientists do anyway, that when you take this synthetic hormone, that it has a similar effect to what the bona fide real hormone does. And it begs the question, I know what we're all asking, why would you ever take anything synthetic? If there's something that's available out there that's natural, that looks exactly structurally like what your body used to produce, wouldn't it be better to take that? And so when I approach patients with WHI study, I try to dispel the difference between synthetic and bioidentical. I teach the patient that synthetic hormones, for example, like an estrogen, like Premarin, like horse, like your urine of the horse, of the Marin, comes from horse urine. Most of the patients are absolutely shocked that that's what's covered by the insurance, or that's what's covered and that's what's written for is a estrogen or a combination of subtypes of estrogen that have been derived from horse urine. And that's only when they pick it up as written from the pharmacy, because most of the time they get some cheap generic that, for only $5 a month, you could get all the horse urine acquired estrogen you want that's off-brand, off-label, and we don't even know where it comes from. So there's a huge variability in the amount or the types of estrogens that are synthetic that the patients are even taking. This is what adds to the confusion of how hormones are affecting our patients and how they're taking them. I don't know if in your practice you use any synthetic hormones?
I do not. I have a few people, or select few, who have been on testosterone shots, testosterone cypionate for whatever reason, and whatever prescription they were on with appropriate lab work, because they've been on a dose for a long time. So my analogy that I give, and see if this resonates with you, is that it's like I need to make a copy of the key for the lock right here. And I'm going to take this key that I have, and I take it to Home Depot for like 25 years. And Bob spins the little thing and he finds the key that looks like it. It's like, key number 23. And he takes that little key down that's on the piece of paper. And if he gives you that key and you take it home, it'll fit in the door, but it's not going to turn the lock. But if Bob takes the key and puts it in the machine with your key and he grinds it down, then you take that key home, then it'll not only fit in the lock, but it'll turn the lock. And that everything that I know to be true is that it's not the key turning the lock that's the problem. It's the process that turns the lock that's the problem. So a synthetic hormone, the processing of it to make it bioidentical, to make it turn the lock, all of that causes inflammation, which increases your risk of clots. So stroke, heart attack, blood clot in the leg that goes to the lung, cancer, all of that. Would you say that's true?
I think so. And, that is probably the best explanation I've ever heard of it. I'm actually going to use that with my patients. I love the talking.
You got to say Bob, because it means more when
it just resonates, I think, with the patients, because it's always Bob at Home Depot. Is that who always makes the key? And I think once the patients understand the whole lock and key metaphor, right? It's the same one for the ligand and the receptor pocket. It's a lot easier to justify and understand. And to your point, many of the patients, by the time they make it to our offices, have hit a pain point. They're at that very brink of divorce or not. They're in sexless marriages, or they're just having so much pain that they don't even enjoy sex anymore, which is just terrible. And it really goes back to what the cause of it is, right? We are working now in a society where technology is abundant, that, it'd be very easy to use a CO2 laser on every patient who comes in saying that they have pain with intimacy or lack of sensation. But I think really requires us, you and I, and other physicians that are thinking like us out there, to put on our thinking hats again. Like, what is really causing the pain? What is causing the discomfort? What's decreasing the sensation? I try to explain to my patients that sex or intimacy it's based on friction, right? So if you start opening up the vaginal walls, you decrease friction. And by the way, men, the endothelial cells within their penis also decrease with time and shrink. So you have men who are shrinking with age and women who are becoming more lax. And that's why we have this issue. It's an issue where lovers who once fit and fit well, now over time, almost in a cruel joke, after having kids, menopause, andropause, what have you, no longer fit. And in our practice, that's all we're trying to do again. We're just trying to get lovers to fit again. And, we've seen so much because we're such a busy OB/GYN practice that at the end of the day, having really good sex makes for strong families. And that's what we're really trying to do here, at least in our practice. We're just trying to make the family strong again. And it's been so difficult, at least in our area. I treat a lot of Asian patients to talk about sex. And I think there's some cultural biases as well as cultural norms of what sex can be talked about and what it can't be talked about. When is it okay to not have sex and when is it okay to have sex? Are there age cutoff? I mean, I think it's different. And what really cuts across all cultural boundaries is the desire for patients to connect again and keep the family strong.
I think it's interesting that you talked about the penis shrinking, because I think I talked about that in one of the podcasts, but I wonder if that's where cougars came from. Like, women are larger and they're looking for younger men who might not have had that shrinkage. Sure. Just thinking about that. But yeah, I agree. I mean, we don't talk about it. And I'm in Texas and it's still in Austin, but it's still Texas. It's more liberal here. But I think just as a general population, like, when do people talk about sex? Pretty much guys in the locker room in high school. And that's kind of where it ends. Once you're married, you're not supposed to talk about it. Everyone knows you're doing it, but you don't want to talk about it. And then certainly when you're not doing it, you don't want to talk about it because then you're abnormal, or then there's something wrong, or then you're broken. And so that's a lot of what I hope to do with this podcast, tell people that they have hope. But there are hopeless people. I treat, postmenopausal women, but honestly, Dr. Tangchitnob, I get a lot of Emily Porters in my office. I get a lot of women who are 30, mid 30s to 40s, not near menopause, who have children at home, whose marriages are suffering. And I had one last week that she had been to the endocrinologist. She had been to the gynecologist. She had been to her reproductive endocrinologist because she'd had IVF, had a 3-year-old miracle baby at home, and a husband who was at wit's end because he has needs and he has a libido and she doesn't. And she gained a bunch of weight and she feels bad about herself and she doesn't want to exercise and she doesn't want to have sex. And she's gone to everybody and everybody has, quote, checked her out and told her that she's normal. One physician actually told her that she was lucky she wasn't fatter than what she was. And
oh my gosh.
So she ended up in my office because she'd heard my name in like 1 week. It was this weird thing from, I think, 4 different people who had crossed her path. And they were not even crossing her path within a really close vicinity of me. I mean, it was several miles away. And she's like, I just feel like I was just led to you. And I heard her and she couldn't believe that anybody wanted to just listen to what she had to say. So you talk, like, I'm going to look up your paperwork. Okay, now you talk. And she told me and I said, I can help you. It's going to be okay. And this is not your fault. And she just started crying. And then she apologized to me for crying. And I am so excited to treat her. I am so excited that her little girl is not going to get blamed for the reason why she doesn't have a libido, and that she and her husband are going to be intimate again, and that with time, managing her thyroid, optimizing her testosterone, she's going to have the energy, the motivation to exercise, to lose weight, and to want to have more sex. And, I saved marriages, and I know you do too. And I really, really just wish that some of our colleagues would just cut us a little bit of slack, because I think I have people, and you probably too, Dr. Tangchitnob, that if you ask them, even if you told them without a doubt that there would be this risk from what they're going to do, like say you said you now went from having a 1 in 100,000 chance of having cancer, just say, to a 1 in 10,000 chance. So tenfold increase. If you told them that, they would still do it, because they say, I can't do this anymore. I can't be like this at 35 and live the rest of my life. And I think some of it is the fact that our bodies have not evolved from the fact that we used to die at 50, right? Like we're now living into 80s. And so people are having these natural slowdowns. Testosterone starts depleting, at 25? Menopause for most women is 50s. And you're living then how many more years, and you're healthy and should be able to do all these things, but you have no hormones on board. And I just think it's criminal that we haven't changed our practices as a result of the fact that modern medicine has made people live longer, but then we're not going to update the way we handle hormones and sex.
Exactly. And I think to your point, if this was the Middle Ages and the average life expectancy was like maybe late 20s, early 30s, that'd be fine. But men and women are going through andropause and menopause, and we are outliving our hormones. And so it would make sense then that to prevent or to treat a lot of the issues that are happening after the age of 50 or even starting at the age of 40 is to replace what has once been created, which is hormones. But as a society, I think the WHI study has really failed us, right? Because, you could see on the cover of Time magazine, talking about what the risks of hormones are, what they can do, what they can't do. And they're all referring to synthetic hormones, never a while ever mentioning bioidentical hormones, been mentioning the pellet, which goes under the skin and just releases, right? And it has really done a disservice, the WHI study, to all women. Because now everyone has to flinch whether they're going to talk about hormone replacement or not. And it depends on where you are. And even more so, it depends on which providers are available in your area or which physicians are available in your area to even listen to you and take the time to talk about what your options are. Now, I'm hopeful because there are people like us out there, Dr. Porter, and there are other physicians who are now learning these techniques. They're coming on board. They're learning about bioidentical hormone replacement. Just in Southern California alone, I have 35 different groups, a combination of OBGYN, I have a plastic surgeon in my group, a Harvard-trained cardiologist, who are all BioT mentees of mine. And they are all treating their own population of patients with bioidentical hormone replacement, with pellets, with testosterone. And I think what's really great about our group is that we're all like-minded, yet we each carry our own background and our own skill set. And being that we all do that, it's back to basics again. Listen, I signed up to become a physician to help people, not to be dealing with the HMOs and to be dealing with insurance and for some other governing body to tell me how to interact with my patient to help them. And it's this start-stop medicine that's really plaguing our society and our community today, and which is really contributing to why patients are not feeling well. So whether we call timeless intimacy or BioT or a laser, at the end of the day, we're just trying to get our patients to feel well again. And I think we finally have hit a cusp now, and we really are at a critical pivot point in medicine where patients are looking for solutions that exist outside of is covered by my insurance.
Yeah, absolutely. I mean, I had a guy to heart pellets and he was on them. And then there's some evidence that urologists saying that somebody who's had prostate cancer, that you're actually decreasing the risk of recurrence of prostate cancer. And I think it's slow, but sure. But I agree. I mean, over 1 million BioT patients alone, and we're just 1
million.
Yeah, one small little thing. I tell people all the time, I said, look, I can't promise you that you're not going to die. I can't promise you that you're not going to have breast cancer or you're not going to have a heart attack. But everything I know to be true is that you're at no increased risk than the general population. But they want studies proving safety, and we're not, or the physician groups do, And even though these have been used for almost 80 years now in Europe, and sometimes I think a lack of something being harmful when it's done in mass numbers, take 61,000 women that had, some of them had harm, versus at least 1 million plus what everyone else is doing. That's, there's tons of ways to get bioidentical hormones. And so I said, look, if this were causing the same ruckus and problems that it did as the Women's Health Initiative, it would be all over daytime television. You're watching, Oprah, I don't even know if Oprah's still on, but you're watching Ellen and there's a commercial and it's, have you had bioidentical hormones? Did you have cervical cancer or a heart attack? If so, you might be eligible for whatever. You hear that about nausea medicine and pregnancy and cleft lip. You hear that about what is it, mesothelioma. There's all those class action lawsuits. The attorneys would be all over it. And so we need to just wise up and realize that somebody just maybe to shut everyone up just needs to sponsor a huge study, a randomized controlled study with double-blinded placebo study where the patient, but in those studies, they have to get their treatment for free. And so it's just, I think the money, there's not a quote, big pharma company like Merz or Pfizer or somebody who's manufacturing bioidentical hormones. I'm not really sure why, because there's got to be money in it with the way the numbers are going. Sponsoring a study like that, it hasn't happened. And until it happens, I don't know if everyone's going to be on board again or on board, with hormones.
Well, I got a simple one for you. Are you pelleted? Do you have hormones in your body?
I do. My mother does. My husband does. And yeah, why would I do something to myself that I even thought for a second was unsafe? And I really wouldn't do something to my patients that I thought was unsafe. And I practice what I preach. And I think if I weren't pelleted, then I don't know that I would in good conscience be able to ethically pellet other people because odds are my testosterone wasn't amazing, because most people at 39, it's not. Then why am I not? What am I holding back?
So
Same with my Botox or whatever, right?
Right. I'm pelleted, right? My mom, dad, both pelleted. I pellet my dad. I pellet my mom. My father pellets me. Every one of our office girls is pelleted, and in our practice, we have a very simple phrase, like, are you living your best life? Are you living your best life is a great way to just begin that conversation, because most people who are coming into our practice, they're up late at night and it's usually at 1, 2 in the morning and they can't go to sleep and they're on Google and they're looking for, something to make themselves feel better. And hopefully they find, information on our website about the bioidentical. But are you living your best life is such a great way to begin that conversation, because if you're not, then what's holding you back? Are you having painful sex? Are you not having sex? Are you overweight? Are you not enjoying or appreciating the way you look? All these things can be addressed if properly counseled with good education. If patients really just understood the importance of taking care of yourself, that go beyond just going to see the doctor for a quote checkup. I don't even know what that means nowadays. A checkup is like getting your oil change or something at the dealership. Well, what is a checkup? What is a well woman annual? It's such a misnomer. Well woman annual. I'm an OBGYN, and well woman annual to us just means it's something else that you check off on the insurance, or your premium goes down each year for the patient. But in terms of what it means for the patient is absolutely nothing. You could get a PAP, but that doesn't necessarily guarantee that you're going to be well. And so I think, to your point, Dr. Porter, we're entering now a different phase of medicine in which the patients have the ability to research and look up information and hopefully have choice.
Yeah. So tell me, if you had, I have this patient, but I want to know, I know how she was managed before she came to me, but how would you take somebody who has this, which I always felt so bad for those women because they hurt all over, and you can't always just assume it's endometriosis, because sometimes you'll miss other things, and they're there and they need pain medication, and it's this cyclic thing. So they'll end up getting all this radiation that they don't need before somebody finally will realize that this is endometriosis and go into a laparoscopic surgery and look at things, and then they get a diagnosis. So if you had somebody who was mid-30s and they had horrible endometriosis that was chronically causing them, pain, they were done having children, they had 2 children, how would you approach that woman? What would you do for her?
I would always approach the patients offering the least invasive and starting there. And I would start by educating the patients that if you really do have endometriosis, then endometriosis, the name has the letter E in it, and so does the word estrogen or the hormone estrogen. And so it's estrogen that is causing endometriosis, that's causing a flare. So endometriosis is a disease that some women have. It's actually 1 in 10, in which there's inflammation inside the pelvis. And estrogen causes the implants, the endometriotic implants, to grow, and it results in a cycle of pain. So painful intimacy, which we call dyspareunia, painful period, which we call dysmenorrhea, and non-menstrual pelvic pain. So when I have patients come and I do my endometriosis consult, I ask them, do you have painful periods, non-menstrual pelvic pain, or dyspareunia, pain with sex? I remember when I first graduated fellowship and I first joined my father, we used to operate together, every Friday doing laparoscopy. And he would always be able to pick out those patients with endometriosis. I'm like, Dad, how are you doing that? We would go in with the laparoscope, which is a small camera that goes in the belly button, and we go in, and he'd always pick out the patients. He was like, son, I asked him one question, and one question only. I'm like, what do you ask him? Now I got to know. Do you miss school or work? Do you miss school or work is such a lead into a 20 to early 30-year-old woman's life that most women don't miss school or work because of pelvic pain. I mean, Dr. Porter, we're talking about the period that's way past the period from hell, right? We're talking about a gut-wrenching, sharp, unrelenting pain that knocks women off their feet. How do I know this? Because my mom had endometriosis. And luckily, she had my father who was treating her on and off with continuous low estrogen, which is low-dose birth control pill. He was timing her cycles. This scanning her. But listen, most women don't have an in-house OBGYN as their husband. And so to the women out there listening to this show, if you have cyclic pelvic pain that may be endometriosis, seek help for it. There are doctors out there who do specialize in endometriosis, and there are great new medical treatments out there that you don't even need to have surgery necessarily to treat your endometriosis pain, because remember, endometriosis is mediated or stimulated by estrogen. So if you just decrease the estrogen, and you don't have to go all the way, because we know when you start decreasing estrogen, you get some hot flashes and some menopause-like symptoms, but if you decrease it just enough, what we call the estrogen threshold, you decrease the estrogen just enough that you can live with the pain and you are functional. You can go to school or work and have sex and not have all the hot flashes and mood changes associated with being in complete menopause. I think that's the ticket. And I think that's what's really changed over the last years. There's a new medication that lowers the estrogen. It comes in a pill form that actually helps lower the estrogen and help with endometriosis pain. Whereas before, it was just an injection that you'd have to come in. And who wants to come get an injection, right?
Yeah, you were saying that he treated your mother with low-dose estrogen?
Well, actually, he treated my mother with low estrogen, which is a birth control pill, and he gave it to her continuously so she wouldn't have her cycle starting around 46, 47, and then bridging into menopause.
Oh, got you. Okay. So he was controlling her estrogen spikes by not having her ovulate.
And so average age of menopause in the United States is about 51 and a half. And she just happened to fit that. And she, at 51, went through menopause, went through the change, estrogen went down, her pain got better. She would tell me, actually now in retrospect, I've actually brought my mom along with me to some of these talks. And, she sometimes served as the patient testimonial, because she would tell the members of the audience that she used to black out and have syncopal episodes from pelvic pain. And we're talking about way past, your mother had it, so you're just going to suck it up, take some Motrin and take some Tylenol. We're talking about unrelenting, sharp pelvic pain that knocks you off your feet. Endometriosis is real. Dyspareunia is real. And I think the sooner we validate some of these things and come up with tools to be able to have patients articulate what they're feeling, the better it is for women.
Well, I had a patient who came to me, has been coming to me for a couple of years now for hormones, and she's probably like 35, and she had a total hysterectomy and oophorectomy. So her uterus and her ovaries taken out due to severe endometriosis all over her tubes, all over her ovaries. And I believe they put her on the patch, the estradiol patch, for like 3 months, and then like yanked her off of it. And they never really even checked her hormone levels to see whether it was effective or not. And she just said, I can't do this. So she gets estradiol and BioT with me. But I don't know why we're still stuck on that Women's Health Initiative study that says the recommendation from the American College of Obstetrics and Gynecology is the lowest dose of estrogen for the shortest amount of time. But who's making that call? It seems very patriarchal for a gynecologist to make that decision on behalf of a woman. And then once, if now the woman, and I can say this kind of as a woman, now once you disagree with your physician, then you're labeled as difficult, as if you weren't already kind of tricky to begin with, because endometriosis you can get labeled somebody who is a pill popper or a drug seeker or whatever. And it's a problem, chronic disease. So yeah, you're difficult because it's really hard to manage. And now if you disagree with your physician, then they dump you. And then you go to another physician, and then now you're jumping physicians. And you're blaming women for something that's not their fault. And for you to blame women for something that's not their fault, and then if they want to do something that's outside of the box that you're comfortable in, I think you owe it to them to say, you know what, that's not my cup of tea. I'm not going to judge or say, whether I think that will work for you, but I'm happy to refer you to a colleague who can give you more information about that. Just like you would if somebody saw an elective abortion and you don't do elective abortions. I think you owe it to them to say, not go find a coat hanger, lady, but let me get you some resources. And I don't know why we don't do that for other things, especially with hormones, because that's not the people that I get in my clinic. They're not referred by other gynecologists. They're referred by other people who are living their best life. And I think that's sad. It's happy for me that they find me, but I think that not only are we not willing to treat women as physicians if we don't agree with something, but we're also just letting them flail. And I don't think that's fair.
Right. And I completely agree with you. And I think what we can do, you and I, is that we just make sure that we create and mount our flags as high and as visible as we can through education, through giving talks in the community, through every single venue we can to really get a soapbox to women and men actually to find physicians like us to listen to them and to treat them. I think it really does enable all to live our best life.
I agree. And I think if we start focusing on testosterone as well as just estrogen, then we're going to recruit more than just gynecologists, right? Because we're getting cardiologists, and now we're getting urologists, and now we're getting family practice doctors. And maybe one day the endocrinologists will get on board as a specialty and start helping people as well. So I think we're on the brink of something, and I'm so happy to be on the forefront with you and timeless intimacy. Do you have anything else, or should we wrap it up and tell them how to find you if they're in LA or they have a friend who's in LA?
Well, kind of a plug for our practice. The website is www.tangchitnobmd.com. You could also Google Timeless Intimacy. We are in West Covina, California, which is essentially in Los Angeles. And we really pride ourselves as being a functional aesthetic practice. And what functional aesthetic practice means is that we do hormone replacement, we do some surgeries, and we also do aesthetic medicine to keep patients looking and feeling their absolute best to live their best lives. So it's been an honor to be on your show, Dr. Porter.
Well, thank you. And I'll spell your last name for them. So it's www.tangchitnob md.com. That's his website. You can find him there. And this was so great. I'm sure we'll find something to talk about here shortly. We'll have another topic because we could talk all day about all the cool things that you're doing out there. So I thank you for joining me. And I hope that I know that we help some people. And that's really at the end of the day what this is all about, is giving people hope, finding their pain, and letting people know that it's okay and that there are physicians out there like you and I who will listen and who can help them if they're struggling and the people who they're seeing cannot. So if you have a question for me or you have an idea for a podcast, I'm happy to hear it. And you can find us at austinlovedoctor.com.
Thank you for joining Dr. Emily Porter, the Austin Love Doctor. If you have a question about your relationship or sexuality, please feel free to contact her directly at austinlovedoctor.com.